Okay, good afternoon, everyone. Thanks for the organizer to allow me to talk about community-based testing and self-testing. I will try to do it in 10 minutes, but I have to say it's quite a challenge. So, as you know, the first 90 is a big challenge worldwide. It is even a bigger challenge, I think, in Indonesia. And the last UNAIDS data have shown that 25% of people worldwide don't know their status. But we have to consider also 15% of those who potentially know but are not linked to care yet. So it's 40% that needs to be linked to care. And the ones that would benefit from more HIV testing and more coverage is key population, men, and also young people. And when you look at the situation of new infections in the region, you see that 3 countries, China, India, and Indonesia, account for more than 70% of the new infection. Of course, they are the biggest country in the region. And half of these new infections are from key population, mainly from MSM. But this means also that half of the new infections are within non-key population. I think this is something we have to carefully consider, especially among clients and partners for key population. So recent modeling have shown that this is now that we have to implement at scale the innovations. I made innovation into bracket, as mentioned earlier, because they are not necessarily innovation. What is new is that we have to really scale up and speed their implementation. And this is now that we have to do it if you want to reach the fast track target and not the dotted line and we do it as usual. So during EIS, there was this document from a decision framework for defining best HIV testing strategies that was issued by WHO and partner, and to set up a client-centered HIV testing model with 3 components: mobilizing, testing, and linking. And you see that partner notification, community, and self-testing as in a same-day art initiation as a really strong part of these strategies. I will not talk about partner notification. We heard the same day, we heard about Roshni, but I will focus on community and self-testing. And we know from the 2015 guidelines from WHO that good practice for HTS should include integration of HTS in different services, decentralization, and I think it's not only through primary health care, but also outside of the health system, and this is where community-based testing is important. And also task sharing or task shifting with increased responsibility of lay counselor or providers to, who are trained, and non-healthcare providers that are trained and able to do rapid testing in the community. And this is a strong recommendation from WHO. So community-based HIV testing aims to offer HTS closer to people in the community.
A little bit slower.
A little bit slower? Okay, that's so scared
I mean,
about
like,
the numbers.
I'm afraid, yeah.
So, and the aim is to overcome, and it overcome many barriers for people to reach testing, and different location, different timing, or in different places. And this allows to reach more first-time testers, and also people who are usually reluctant to use clinical services, which include men, most of them, and adolescent or key population. They use finger prick testing. The programs can be designed for different subpopulations. And the new technology and mobile phone are very helpful now to increase efficiency. One of key issues is the linkages to prevention and treatment services that we talked about. And there are different ways to do community-based case testing, mobile testing, we heard a little bit, event-based testing through national campaign or local events, home-based testing, door-to-door, but also PL-HIV and TB household testing is also a strategy. Proposed testing at workplace or in educational places like universities where you have many young population there that can be a helpful strategy. Important component is, of course, peer outreach, where trained peer go to venues and specific hotspots to reach out to reach groups, such key population or adolescents. So this is not a testing strategy, this is a test for triage strategy. It's more as a screening, and of course we need to link to confirmatory testing, and linkages is here absolutely critical. But it's just important to consider that we have to put our resource and effort on a less number of cases, because we are dealing only with reactive cases, and given the low prevalence, it's very few cases. So putting our energy to make sure that 100% of those guys are being enrolled is not so huge a burden for the system. And I just want to illustrate what has been implemented for many years in Cambodia, which we call active case management. It's like the navigation approach that we talked about a little bit, to ensure that all reactive cases are linked to confirmatory testing and ART. And you have what we call a case manager supporter at community and case manager provider at facilities that will inform an OD centralized active case management with a coordinator and assistant about any new reactive cases. And with the database here, this level will be in charge to follow up each cases and make sure they're enrolled in care and started on RT. This can work for many other functions along the HIV cascade and what has proven to be very effective. So we have many evidence that community-based HIV testing is working with a higher rate of HTC uptake, increased rates of first-timer tested being tested, increased rate of early diagnosis. There is a lower positivity rate, but this is what we expect compared to facility-based approach. The linkages are efficient, and 80% got a CD4, 73% in this meta-analysis found that was initiated if eligible. And at the population level, this clearly increased coverage. No harm were reported, and the cost can be calculated, and sometimes it's not so high per patient reached. So now what's a recent modeling issued by UNAIDS about what could be the ideal HIV testing scenario in countries. You can see that when we here, and the red line is today, and you see that in the near future, HIV self-testing and community testing in yellow will have to be increased, while VCT and PITC will remain almost same, and eventually will decrease for VCT once epidemic will be controlled. But HIV self-testing remain quite an important component, and PITC will increase. So clearly, self-testing is becoming a key case-finding strategy recommended by WHO since 2016. It can be done in either assisted or unassisted fashion. And during the EIS, two documents were issued. One is a guide for planning and introducing and scaling up HCC for countries. And another one is from UNITAID, a market landscape for self-tests available. Today we have 8 HIV self-tests available, which have been either approved and pre-qualified by WHO, one very recently in November, or approved by SRA or the expert review panel from Global Fund. So now we have many evidence and many, and I can refer you to this meta-analysis review recently published, that self-testing is highly sensitive and specific, maybe higher for blood versus oral self-test. It's accurate, it's highly acceptable by many different groups in different settings. Oral test is much preferred by communities. There is no social harm reported, and importantly, no increase in the HIV risk behavior or STIs. And that was a concern when people see they are negative. They can have whatever they want, but it's not happening. Self-testing has been shown to double the level of HIV uptake in MSM population, and also increase the rate of those who need repeated tested because of their risks. So it's also a test triage approach, as I described for community self-testing, with the same requirement of a confirmatory HIV test. The interpretation of non-reactive has to be balanced with the risk of HIV exposure and the window period eventually. It's also not recommended to test with self-testing the people who were already on ARV, and we find many false negative in these cases. That is something we should be aware and ask people if they are or not on ARV before proposing testing. And what is a little bit specific for self-testing is the importance for additional support tool to really teach people how to use the test and get support for counseling, referrals thereafter if they have been found positive, and there are outlines and many different tools available, which are very helpful. You here have the last and updated number of countries that have policies. So 59 have current policies, 53 are developing policies, and Indonesia is one of them. But the implementation is still slow, and only 28 countries really implement, and mostly in middle and high-income countries. So a lot still need to be done to scale up HIV self-testing. So the question is how to adapt self-testing services to the context, because it can be delivered through community, through partner delivery, and at the facility, as we have seen previously, in different places and pharmacy, workplace, or integrated in different services, and also through internet, can be available through different channel, internet prep, and also vending machine. So it's important to adapt the distribution and the program to the national and the subnational epidemiological data and focus where it's mostly needed. So I cannot not talk about self-testing without mentioning the recent report published in the 1st of December for the STAR project in Africa. It's a real large-scale project to take self-testing to scale at this level and learn from program implementation. Many distribution models have been tested. 2.3 million tests have been distributed, and the main lesson is that it reaches a higher proportion of men, young people, and first-time testers. It's increased testing coverage in the population studied, and it has a significant impact when it is used at the health facilities. And it also helps countries to move faster in policy and practice and regulation. As mentioned earlier, and this is the same abstract we heard about, is facility-based HIV testing dramatically increased HIV testing in a program in Malawi. And this was compared to PITC or optimized PITC, and you see this dramatic increase of self-testing uptake in this different age population. They got a similar positivity rate, of course, but the increased number of new positive, which even with lower linkages rate, led to an increased number of people started on ART in this study. And they have also another abstract showing that this approach at facility is cost-effective. Another interesting aspect of self-testing distribution is secondary distribution. That's increased the rate of testing for male partners, for young women in Kenya. And women were proposed either oral fluid self-testing or partner classical referral. And you see a dramatic increase by more than 40% of testing male or in couple HIV testing in this setting. No intimate partner violence were reported. On community, so in Thailand and Laos, self-testing is being delivered in communities, a linkages program to work with MSM and TG. It's used OraQuick and mobile and internet-based tool. And you see in Laos a rapid increase of HIV testing uptake with a strong strategy to link it, the positive, and 96% were linked to care in this setting. And however, in Thailand, so assisted self-testing were preferred, as the linkages I've shown previously were not so good, and so some really intervention needs to be done in Thailand to support. So it's not impossible because we could do it now, but clearly in different contexts you have different challenges. So for HIV self-testing, what's the benefit and limitation? We talked about this. I just want to insist here about the need for confirmatory testing and the importance of linkages. The importance of additional support for self-testing. And of course, it's vital to have policy and regulation in place in country to allow procurement and a good cost for self-test. I didn't talk much about many challenges because it's important, especially for unassisted self-testing and secondary provision of self-test, because you provide and you switch the test to individuals outside facilities, so the collection of data is much more problematic. I just want to remind that the best is the enemy of the good, so we should not take it as an argument not to implement self-testing, even if we cannot be perfect and there are many parts, because we know this is a working strategy, and this might have an impact on the country. So in conclusion, just say that community-based HTS, index testing, and self-testing have really the potential to impact the first 90, especially in Indonesia where it's a great challenge. Self-testing can be integrated into community, index testing and partner notification, but also at facility. And I think this is a good opportunity because I completely believe that we have a missed opportunity of HIV diagnosis in facilities everywhere, and self-testing can really help to improve PITC and testing at facility when people go, because they have a reason to come to the facility, and we should not misdiagnose them at this level. So I think self-testing can really help here. Secondary self-testing distribution, I think this is an interesting option, especially here that we are pushing for partner notification. It can also improve and synergize with the current strategy, which is mainly based on referral, and we have argument to say that it's efficient in other places. We need to design special support for linkages, both for community testing and self-testing. We have navigation somewhere in place in some setting, and this has been to be optimized for this approach. Additional support tools are important for self-testing, and a lot are available. No need to reinvent the wheel, but adapt what is available. Cost effectiveness of self-testing, I think, should be further studied. We have evidence in some places that it is cost effective. It could be because of the high acceptability and the positivity rate in covered populations. I think this is an interesting study to be done. Finally, the lesson learned with self-testing could really benefit to many other diseases, especially hepatitis, malaria, STI, or HPV, and eventually through multiplex platform, as people are working hard actually. Yeah, thank you, Tim.